We've now reached the pathology section of the endocrine chapter. Let's talk about all the different ways things can go wrong with the endocrine system. To begin, let's discuss Cushing's syndrome, which is a common set of clinical findings from a variety of underlying causes. The one universal feature is that there is excess cortisol, and the clinician's main job is to figure out the source of the cortisol. The most common cause by far is exogenous administration of steroids. Steroids are useful drugs that doctors prescribe for a variety of conditions, but unfortunately, if used excessively, they can cause Cushing's syndrome. In the less common situations, where the sources of excess cortisol are endogenous, 70% of these cases can be traced to a pituitary adenoma secreting adrenocorticotropic hormone, or ACTH. When Cushing's syndrome is caused by a pituitary tumor, it is known as Cushing's disease. The remainder of cases can be attributed to either ectopic ACTH secretion from non-pituitary tissue, such as the infamous small cell lung cancer, or from adrenal adenomas, carcinomas, or hyperplasia. ACTH serum levels are useful in differentiating these different causes of Cushing's syndrome. If exogenous steroids are being administered, they will negatively feed back on the hypothalamus and pituitary, which is manifested by low levels of ACTH. Similarly, if the adrenal is autonomously producing high steroid levels, negative feedback will result in low serum ACTH. However, if there is a high ACTH level and high cortisol, you know that the reason for high cortisol is the high ACTH, either coming from its usual source in the pituitary or from an ectopic location, usually the lung. In order to differentiate these last two options, clinicians can perform what's known as a dexamethasone suppression test. Dexamethasone is a synthetic glucocorticoid and therefore will also cause negative feedback on ACTH levels. A patient's blood levels of cortisol are measured before and after administration of low-dose dexamethasone. In a normal person, cortisol levels would be lower after dexamethasone administration because the synthetic glucocorticoid suppresses endogenous ACTH production. Patients with Cushing's syndrome, however, do not typically respond to the low doses and cortisol levels remain high. To differentiate the various etiologies of Cushing's syndrome, the next step is to give a high dose of dexamethasone and measure blood levels of cortisol for a third time shortly after administration. Reduction in cortisol levels by high dose but not low dose dexamethasone is indicative of Cushing's disease, or an ACTH secreting pituitary adenoma. If the cause of Cushing's syndrome is an ectopic source of ACTH or cortisol, cortisol levels will remain high after both low-dose and high-dose dexamethasone. However, ACTH will be high for an ectopic ACTH-producing tumor, but low for a cortisol-producing tumor due to negative feedback. So we've talked about some of the lab testing for Cushing's syndrome, but what exactly are the clinical features of the disease? Some of the obvious external signs include weight gain, moon phases, trunco-obesity, buffalo hump, and skin changes such as thinning and violaceous striae. Worrisome cardiovascular issues include hypertension and hyperglycemia from insulin resistance. Longer-term effects, which become important for patients on long-term steroid treatment, include osteoporosis, amenorrhea, and immunosuppression. We're going to transition now to some diseases of the adrenal gland. Hyperaldosteronism, as the name suggests, is a disease with extremely high levels of aldosterone, which you should recall is produced in the zona glomerulosa of the adrenal cortex. This can be either primary, meaning the adrenal is autonomously secreting more aldo than it should, or secondary, meaning there is a signal causing the adrenal to produce too much aldo. When it is primary, there is an aldosterone-secreting tumor. This is known as Conn's syndrome. The effects of having too much aldo in the circulation are hypertension, hypokalemia, and metabolic alkalosis. Because the high blood pressure is detected by the kidneys, there is no stimulus to secrete renin and plasma levels are low. A side note on this tumor is that it can occur either unilaterally or bilaterally, and it can be treated either surgically or chemically with spironolactone, a competitive aldosterone antagonist. Patients can also have too much aldosterone as an effect of excessive adrenal stimulation. You should remember that angiotensin II increases the production of aldosterone. and that angiotensin II itself is formed after stimulation by renin. So there must be a high renin level, and the physician's job is to determine what process is causing the high renin level. Some reasons for the kidneys to secrete excess renin include renal artery stenosis, chronic kidney disease, congestive heart failure, cirrhosis, or nephrotic syndrome. Most of these conditions cause the kidneys to perceive the intravascular volume as being abnormally low, and they respond by upregulating renin production. You'll hear much more about how these disease entities involve or interact with the kidney in the renal lectures. At the other end of the spectrum, we have a disease entity where the adrenal cortex is failing to function properly. Addison's disease is defined as chronic primary adrenal insufficiency and can be related to adrenal atrophy or destruction of the gland by autoimmune diseases, tuberculosis, or metastatic cancer. Because the aldosterone production is compromised, patients develop hypotension, hyperkalemia, and metabolic acidosis. Compromised cortisol production causes weakness, anorexia, GI disturbance, and weight loss. A telling sign of the disease is increased skin pigmentation. Patients appear to have tan skin even without large amounts of sun exposure. We'll go back to the hypothalamic pituitary axis in order to understand the symptom. When cortisol is produced, it feeds back to the hypothalamus and pituitary to decrease further production of corticotropin-releasing hormone, or CRH, and ACTH. Since cortisol is not adequately produced in Addison's disease, there is no inhibition of the hypothalamic pituitary axis, so we get an increase in CRH and ACTH. Recall that ACTH is not the direct product of the corticotropes in the anterior pituitary. In fact, ACTH is a subproduct of pro-opiomelanocortin, or POMC. Another subproduct of POMC is melanocyte stimulating hormone, or MSH. Therefore, if ACTH goes up, then MSH also goes up, which causes the hyperpigmentation. An important aspect of Addison's disease is that it affects all of the layers of the adrenal cortex, but spares the medulla. Also, you can have similar clinical findings in patients, that is, weakness, anorexia, GI disturbance, weight loss, hypotension, and acidosis, but no skin color changes or hyperkalemia. In this situation, you are likely dealing with secondary adrenal insufficiency, in which the adrenal gland itself is functional, but there is reduced secretion of ACTH from the pituitary. Laboratory tests can easily distinguish these. Based on this information, what do you think tertiary adrenal insufficiency is? That's right, reduced CRH secretion from the hypothalamus. So far we've discussed primary adrenal insufficiency in its chronic form, that is, Addison's disease. But patients can also present with acute adrenal crisis due to adrenal hemorrhage, also known as Waterhouse-Friderichsen syndrome, which is associated with Neisseria meningitidis septicemia, disseminated intravascular coagulation, and endotoxic shock. Of these three etiologies, the link between Neisseria septicemia and Waterhouse-Friderichsen syndrome is the most frequently tested. This devastating syndrome consists of shock, coagulopathy, and petechial rash. Now we'll talk about two tumors of the adrenal medulla. The first is the infamous pheochromocytoma. This is a tumor that usually occurs in the adrenal medulla, though in 10% of cases it is found in other sites of the body, such as the paraganglionic tissue near the abdominal aorta. The tumor derives from chromaffin cells of the neural crest. The major products of pheochromocytoma are epinephrine, norepinephrine, and dopamine. The sporadic secretion of these catecholamines causes episodic hypertension, which is a cardinal feature of the disease. You should be familiar with the pathway on this page describing the metabolism of catecholamines. Also recognize that the final conversion from norepinephrine to epinephrine occurs only in the adrenal medulla because it requires the PNMT enzyme that is only expressed there. Diagnostic testing includes checking levels of plasma catecholamines as well as looking for breakdown products in the urine such as HVA, normetanephrine, VMA, and metanephrine. Definitive management of these tumors is surgical, but patients must get their hypertension under control for a period of months before they can have a safe operation. Typically, an irreversible alpha antagonist such as phenoxybenzamine is given first to avoid a hypertensive crisis, followed by beta blockers to reduce the heart rate. Recall from the pharmacology lectures that epinephrine and norepinephrine cause vasoconstriction by acting on alpha-1 adrenergic receptors. So an alpha blocker will prevent hypertension even when there are high levels of catecholamines in the circulation. So how would you recognize pheochromocytoma on an exam? There are 5 major signs and symptoms, and they all start with the letter P, so it's easy to remember. Pressure, as in high blood pressure. Pain, and that's referring specifically to a pounding headache. Perspiration. Palpitations, which are associated with an elevated heart rate. And pallor. Patients won't present with a complaint of high blood pressure, but they may come in and say that they're having a headache, perspiration, and palpitations, the so-called triad of pheochromocytoma. You may have heard about the rule of tens for pheochromocytoma. Pheochromocytoma is traditionally described as being benign, unilateral in the adrenal medulla, and occurring sporadically in adults. The rule of tens gives you all the rare findings. In 10% of cases, the tumor is malignant. 10% of the time, it will occur bilaterally. 10% of tumors are not in the adrenal. 10% of the tumors are calcified on imaging. 10% of cases occur in children. And 10% of the time, it occurs in families. In the rare cases where pheochromocytoma is familial, it is usually associated with neurofibromatosis, MEN2A, or MEN2B, where MEN stands for multiple endocrine neoplasia. We'll discuss MEN in detail in a few minutes. Cancer in children is quite rare in general, but neuroblastoma is one of the more common solid tumors found in children. This tumor occurs in the adrenal medulla, or anywhere along the sympathetic chain. The tumor is typically discovered by physical exam. Parents or physicians note an unusual growth in the abdomen, though there are many other clinical features. Lab testing includes elevated urine levels of homovanillic acid, which is a breakdown product of dopamine. These patients are less likely to develop hypertension compared to patients with pheochromocytoma. The key oncogene for this tumor is N-MYC, which has been associated with rapid tumor progression. Histologically, neuroblastoma is characterized by small round blue cells that form Homer-Wright pseudo-rosettes. Remember this important association for the boards.